Hello, everyone. Welcome to the show. I'm your host, Ernie De Los Santos, founder and faculty chair of the Peel Academy and creator of Top Gun Audit School. We are live on the March 18th, 2016 edition of Finally Friday, and I want to thank you for choosing to spend your time with us here on Finally Friday. Today's Finally Friday broadcast is sponsored by the Health Law Partners, providing solid advice and real solutions for healthcare business nationwide. Finally Friday is now also sponsored by MedLink's Cost Containment, makers of the Healthcare Audit Tracker. You can visit zerodenials.com today to see how they can help you track audits and greatly reduce or even eliminate denials. Maybe you can even say that better than I can. We have a new sponsor now, MAS Coding Solutions. They're a leading healthcare consulting firm out of Charlotte, North Carolina. I got to slide out of order. There we go. There's MAS Coding Solutions. They have 25 years in the medical coding industry, over 25 years, and they have core competencies in medical coding solutions and medical coding education. We also partner with Recovery Analytics, Sharon Easterling's company. She does auditing and education and authors articles for HMA. And then if I go backwards a slide, I get to we are also partnered with the Council for Certification of Medical Auditors, the CCMA. They are the creators of the widely used Certified Medical Audit Specialist, or CMAS certification. And as of today, we are proud to announce that we have been approved to offer CEUs for our shows for CMAS certification. So if you hold CMAS certification or you want to get one, you can be sure that you can get a 1-hour CEU every week by watching Finally Friday. That's pretty cool. Let's see. Oh, somebody's saying thank you in the chat room for explaining to viewer 95 how to get the audio. There are 2 ways to get the audio. Of course, they can't hear me. So anyway, if somebody can help them out there while I get going, that'd be great. Okay, so let me get back to the slide deck. Oh, before we, to do all this today, I have 3 people on hand to help me out. We have our special guest, Dr. Deepak Pahuja, who is the Chief Medical Officer at Aerolib Healthcare Solutions. He is a working hospitalist and a physician advisor, and he's going to help us look today at sepsis and these new definitions from the physician side. And then I have my 2 panelists, Sharon Easterling, who I've already talked about. She's the founder, auditor, and CEO of Recovery Analytics. And then we also have Bill Mom, who's a CMAS and physician assistant. Okay, now wait a minute, I want to go to the website. Let's go here and bring that up. Okay, I just wanted to explain to people who might be new to the show that we have on the website, if you are not familiar with the room or how to use the control panel, it's got some green buttons at the top of your screen. If you scroll down any page on PeelAcademy.com, you'll see this with the green buttons like you have on your screen. If you click on that, you get over here, and it shows that you have what to do with the buttons. So you can find out how to connect more if you can't get on the phone or can't get on the audio. Or one or the other, you can usually get to the other to get the audio. There's also the chat box. I highly recommend you open the chat box, which is the second button from the left, because that is very active during our shows. If you already got it open, you can see that we have chat box blowing up already. I expect it to be very active today. You can also zoom in on the screen. Now, you want to keep this in mind today because there are some screens that we have that may have text too small for you to view at your end. I'll try to zoom in on things, but in case I'm not zoomed in far enough, you can do it yourself. You can also see the list of participants, second button from the right. and that is where you can identify yourself. Now, just so everybody knows, we record the show. We do not record the participants list or the chat box, so everything there is not recorded and is not discoverable, in case anybody's concerned about that. There's some more options on the right, but forget that. I'm not giving you control of the show. So, okay, with that, let me get back to, I think everybody knows, you probably know how to get the handouts. If you're not sure about that, you click from the front page, you click on this Get All the Details. It takes you into the This Week on Finally Friday page, which you can also get to from the main menu. And if you scroll down, you see this, there's always this one that says Get the Handouts or Watch for the Handouts. Click on that. It takes you straight down the page to this blue box. Enter in your email there, and it will give you immediate access to the PDF of today's slideshow. Now, unfortunately, if you got that deck before about 12:30 Eastern Time today, what happens is I added a bunch of slides to the show at the last minute because Bill and Sharon and I were just talking. There's so much to talk about today. We added a bunch of slides. So you need to have the version that says it's got the handouts title, and then at the end of it, it'll say V2 or V3. You want V3. That's the one we're using live on the show today. So apologies if you downloaded the older one. The newer is the one you want. And of course, there will be the recording will be available after the show, shortly after the show. And then this is where you go to get, if you want your CMAS certificate. I will have this here on the This Week on Finally Friday page every week. So you click on that. Let's see, you see what it does. And it takes you to a page where you can download this CEU for a CMAS CEU. Can you use that with anybody else? Heck if I know. You're going to have to ask your organization if they will accept these kind of CEUs, and maybe you can get half credit for that. But anyway, that's a 1-hour CEU available every week through Finally Friday for CCMA. Okay, now, where was I? Okay, I think I want to get back to the slideshow now. All right, so last week on Finally Friday, we talked about the SNF reviews of the resource utilization groups and coding validation reviews, and how CMS is now sticking the racks onto the SNFs. That was last week. This week, we are talking about this is the third version of definitions for sepsis and septic shock. And this darn thing has been around, the definition of it and treatment of it has been known for about 5,000 years. So it's kind of crazy. But after 5,000 years, we still can't come up with a definition. Why is that? So the task force took into mind trying to improve that, and we'll get to why all the fuss as we go along, and even talk about a little bit of the history of sepsis. This is interesting. There's a really fun music video that was done by Kern Medical Center, and there's a link to it here. The thing that was so alarming to me was they're saying 590 sepsis deaths daily in the U.S. alone, and I think that's an old figure, and it's gotten higher. So really kind of an odd thing. But the basic thing is, I believe most of you on the call are very familiar with that progression from STIRS to sepsis to severe sepsis and septic shock, and all of that. The weird thing is that you may not get paid more for it going up here, but you got to document it, right, to get paid at all. And so now they're doing a lot of things to change the way it's all defined. See, Dr. Hirsch commenting, yeah, life is 100% fatal. We all die. It's not optional. Well, very true, but this is not something I want to die of. As a matter of fact, I don't think I know anybody who would want to die of this. Anyway, okay, let me go through a couple of news things. before we get to the show itself, really not too much in the news this week, although CMS released this new mapping tool that maps Medicare disparities across all kinds of things. It's really kind of a neat tool. But it's, if for population health, if you're involved in population health management, then this is something you may want to take a look at. And that is, but it just came out this week. It looks pretty cool to me, but I don't do that kind of work. But I thought we should bring it to everybody, bring it to your attention. So if you know somebody and they're looking for that kind of thing, there it is. Biggest news I've got this week is that we are able to provide these CEUs. I've already told you about that. There's no exam required. If you do this, they're going to be available. Now, each week's CEU certificate is available until the next show. So that's the one caveat. You don't have to take an exam, but you can't wait 2 weeks and then go watch a bunch of shows. So you got to watch it this week. That's the caveat that CCMA put on it, instead of making you take an exam. Not bad. So there we go. The other thing I wanted to talk about was this new Coding Connection. It is a seminar that's being held in Charlotte, North Carolina, and is being hosted by Mass Coding Solutions. That's Mary Gregory and her company, who are now a sponsor. They really like what they see on the show, and they wanted to be able to connect with everybody. And, of course, they want me to tell you about this. And, Sharon, can you talk about this for a minute? I'm going to pull up the website for the show and talk about it just for a minute to let everybody know what it's about. Sharon, are you with me?
Yeah, I am. Mary and I have been talking about doing a coding conference for a while here in Charlotte, and we decided to pull together something with some physicians that we've worked with, as well as some CDI professionals and coders. A concern definitely is just moving to 10 and how 10 has transitions from introduction to application to mastery, and we're trying to provide more information for folks to get to mastery level since we're still in the application stages where we're just learning how to apply those codes to what we do every day. So that's really what the conference is about. I think one of the physicians that's involved, Mary, does quite a bit of training with physicians. Let's say you want to get your CCS certification or your clinical documentation certification. Mary has partnered with a number of physicians, and they're now CCS and CDIP or CCDS, so it's been pretty interesting. So,
yeah, we're going to have one of them come on the show and talk about that and how that's been a help for them. And they're a physician with that certification. And they also have some really terrific, it's not an expensive conference, but there it is. It's in April. Anyway, so please go check that out. Just take a look at it if nothing else. Okay, so let me get back to here, and there's the link for going in to visit that. Okay, so this week, this is the main thing that we're using to talk about this week. This got started because Sharon had listened to the ACDIS radio show from last week, I think it was, Sharon. And yeah, they mentioned this, and I talked with Brian Murphy about coming on and talking some more about it, and we were trying to arrange somebody from ACDIS board to come on and talk, and that may be another week. As a matter of fact, we may try and do that next week because there's so much to talk about here. I think we're going to do another show about some of it next week, and I have some other physician advisors in mind to come talk about how they deal with this, in particular how they deal with it on rounding. Which I thought was a very interesting article, or a very interesting topic. Now, the big deal about this is that, yeah, it may look like there's not much change, but actually there's quite a bit, and it's going to be kind of a problem. That's what Sharon started talking to me about. At first we weren't sure we could do a whole show about this, and then as we dug into it, we thought, no, this is at least one show. And the problem is that it's change at all. Nobody likes change, right? Everybody dislikes change, although some people, they want to talk about it like, oh, well, it's a process, it's not an event. And my answer to them is, okay, fine, you first then. How about you go change first? I'll follow you. Okay? Some people don't like that answer. So, the way we all want change to work is that it can do these kind of things to us, where we discover or create or we're inspired and everything. But quite often, this is what we wind up with, is instead we're going to be confused and bewildered. And actually, I think that may be true for a lot of people in the industry. And, the question is, why is that so? Why is that such a problem? It seems like, well, it ought to be kind of simple, right? There's some kind of an infection that causes some kind of organ injury or bodily member injury, right? Why are we doing a third consensus definition? Well, the problem is because it's been around for a long, long time, and it's very difficult to be categorized because there's so many, as it says down here, it's diverse clinical manifestations. So I went and looked up, I started reading about the history of this last night, and I found some very interesting articles. Here are a couple of them that I highly recommend. I really dove deep into this one on the history of it from ancient Egypt up through the 19th century. And what you find is that, it really is the earliest written record of somebody talking about something that we would call sepsis. They didn't call it sepsis then. They were Egyptians, not Greeks. This is a picture of possibly one of the oldest known physicians in history. Maybe he was treating it because there are papyri found that date back as far as, or perhaps quoted an older manuscript as old as 3000 BC. That's 5,000 years ago, folks. And it talked about 48 different cases that we would call sepsis. So here's where you can read about that if you're interested. And then going up into the early, much later time, a couple thousand years later, you get the Greek definition, and it was actually first the word for sepsis, or SIPO, was first used in that time. We have first evidence of it in the Iliad. And then later on, that Greek definition really shows up being used by Aristotle and Hippocrates. So there are more things like that. And then we come to the Middle Ages, and you get the first medical context bibliographical reference. It's from something that was written in around 1500. So the 15th, 16th century. But this was actually, well, those are the oldest versions we have of it, but it was written by a guy from the 13th, 14th century. So again, it's been around for a long, long time. Well, in 91, there was an international conference convened, and they decided to try and define it, because it was so complicated. So they came up with this. Now you can get a link here to go look at the original definition there. There was a lot of people complaining that it just didn't go far enough. And so in 2001, there was the second International Sepsis Definitions Conference was convened to try and improve on that, but there was still a lack of evidence, and it still provided a big problem, big holes in it. So that's why we have come to this third version, Sepsis 3, and this was just released last month. Part of the reason that they did it was because, as they say here at the bottom, in effect, the definition of sepsis, septic shock, and organ dysfunction has remained largely unchanged for more than 2 decades. I don't know that that's that much of a deal, considering it's been around for 5,000 years. But anyway, so what they were doing, and there's several articles. I'm just going to flip through these. But the articles themselves are available in that original article that I'm going to talk about in a minute. And here is the link where you can go find these articles. So out of the download the deck, and you can open these directly out of your PDF. to go find all of these. So this one talks about how they're trying to develop new definition and identify the clinical criteria to validate it. And then they're talking about, well, how do we validate the clinical criteria? Because that's a good question, right? Just because somebody came up with it doesn't mean it's valid, and you're going to have to talk about it some more. And this is where they come up with, this is where you first start seeing the mention of QSOFA, and we'll talk about that in a minute. And then this article that just came out, which was done by Ed Abraham, who I think is part of University of North Carolina or Wake Forest, one of those, I think, or am I confusing you? Anyway.
No, he's the dean of the medical school at Wake Forest.
Okay. And we may even try to get him to come talk to us a little bit more about this, so we'll see. But basically, all of this, you can find all of these things and reference all of them from this article right here. And it has a very simple, it's jamasepsis.com, where you get to this article. And from here, you can then get to read the full article, although you have to register for JAMA, but that's free and easy, and you can get reference, get the complete article. And then there's a ton, there's like 8 or 12 videos about all of this down below that I don't show on the page here. Basically, this is what the task force recommended then. This definition for sepsis and septic shock and the clinical criteria that you use to get to those diagnoses. Now, we're going to talk more about that in detail a little bit further on. And then you have this, which is an organization. It's a European, I forget. They were responding to the European Society of Intensive Care Medicine's
right. Ernie,
and sepsis 3.
This is a statement from the Surviving Sepsis campaign. They provide us with some of the clinical clarifications for how we apply sepsis for within our hospital for care planning, as well as for the patient safety indicators with CMS, some of the performance measures that are used. So they made a statement related to the changing of the definition and some of the criteria and how hospitals are to move forward when it comes to their quality improvement initiatives. And basically they're saying that, look, we're aware that there's a change in the definition of how we're defining sepsis right now and how we look at it clinically. However, we're going to take that information and sit down and make a decision on it. But for now, do what you are doing to meet these measures. Follow your measure and do what it says. And then that way you're safe for now. So it'll be down the road as far as if they look at this and say, okay, we're going to change the way this measure is reported. I think we do have a PSI in here for post-op sepsis determination, but for now we're just going to continue to do what we're doing.
Yeah. And this is, so this one is about the implications, and that is what we're going to spend most of the rest of our show talking about. And I'm sure a document like this is going to show up on Monitor Monday now, this next Monday, because that's what they do. But we'll spend a lot of time talking about it. No, she did not just say, somebody said, did she just say to ignore it? No. No, you don't want to ignore it. What we're going to talk about is what you need to pay attention to.
Well, and what I'm saying at the Surviving Sepsis campaign, this is official, so you can go out there to this website, survivingsepsis.org, and that's where they reported that here in this fourth line of this sentence about how organizations are focused on quality improvement programs. If you're involved in a quality improvement initiative around sepsis, you should be continuing to do what you are doing as far as how you measure that and how you're doing that in your hospital. And you can go out there and take a look at this. It's the whole page just on, we're aware, we know this has happened, and we're going to come out with something later on it.
Yeah. So anyway, let's go take a look at some of these, and then there's a lot of documents that talk about this, and we'll get into what these implications are. Okay, so this original article link goes back to the Sepsis 3 definitions article, and that's on several pages. But so this is what surviving sepsis is talking about, and they're saying that the first step needs to be, of course, the screening and management of infection. Yeah, go ahead.
Can I stop you for a second, because I see in the chat box that is still clear. So go back to the surviving sepsis complaint slide.
Okay. All right.
Okay. So, and as we move through this, I think you'll see it better. So, JAMA, they got together, they did this research, and they came up with how we should view sepsis and what we should do. So they kind of posed a new guideline for us. And how we operationalize that, how we use that, and what we do day to day is still undetermined. So it's guidance out there. So when folks like the Surviving Sepsis Campaign folks and the AHIMA folks and AHA folks get together, they can use that evidence-based research to make a further decision, to guide us how we do this going forward. But for now, that's just evidence-based medicine. They have to vet that. They have to look at that. They have to say, okay, we have this new definition. How does this play into what we're doing with our quality measures now? And if it does play into it, how do we act upon it? We don't have that direction yet. Surviving Sepsis hasn't made a decision yet. AHIMA hasn't made a decision yet as far as coding definitions and how those things play out. So for now, the message is continue to do what you're doing, keeping in mind that change is coming. And that's kind of what we're talking about today, the road to change, and what potentially could that road look like? How do you vet that once these organizations come out with that? Of course, they're not going to give you all the tools and all the information you'll need to effectively, and I say effectively, do that in your hospital. There are going to be humps and bumps and things that we're still going to have to manage through. And that's kind of what we're talking about today. But no one's changed any guidelines. No one's changed any standards. The code book is still the code book. All those things are still in place. So we can't totally stop doing what we've been doing because we have this new evidence-based research and information. Does that make sense?
I think it does. And what we're going to do is we're going to show you some tools that they've given for this. So if I move forward through this, and I'm sorry if I'll go through a couple of these kind of quickly. This is straight out of that document, okay? These next 3 slides are basically straight off of this document, but that's what they're talking about, okay? Step 1 is in the screening and management of an infection, okay? In other words, this is what they're saying. How you treat them, from what I'm hearing, Dr. Prahuja, please chime in, and Bill, but if I understand this correctly, there's no change in how you treat sepsis or how you treat somebody who's suspected of being septic.
Yep, that is correct, Ernie. And when a patient comes in with hypertension and signs of infection, the definition may change. It has changed in the past. But the initial management, what we do in the first 3 hours, what we do in the first 6 hours, lactate levels, blood cultures, antibiotics, IV fluids, making sure they have adequate volume status, that does not change. What has changed definitely is what the hospital and what CMS would want documented in the chart in order to ensure that adequate payment is being made for that diagnosis. But from a treatment standpoint, nothing has changed.
Okay. Dr. Hirsch asked a good question. Are we asking doctors to basically give a different diagnosis because these guidelines are changing, or I don't really
Ernie,
see it being
I'm going to speak to that. I don't think so. I think all they're doing is trying to clarify what sepsis is. It's a grouping. It's a syndrome. I think it's another attempt to try to clarify what sepsis is, make it a little clearer, so that when there is documentation in the chart about the treatment plan, what have you, it kind of gives it a little more oomph. I don't know that they're asking you to document anything differently. They're certainly not asking you to treat it differently. And I'm not sure that any of this is more than an attempt to further clarify for the benefit of all parties what sepsis is and put it on more of a stable platform. Early recognition, here's another screening tool. Millman doesn't have it yet. Interqual doesn't have it yet. It's just another screen. I don't think anybody's asking for different documentation. Sharon, would you agree?
Well,
actually, Bill and Sharon,
go ahead.
Yeah, I'm going to have to disagree with you there, Bill. The documentation has definitely increased. The burden of documentation for sepsis is much higher than it was prior. And even when you look at Q Sofa, just look at the variables that they need: the respiratory rate, the ABG, the PaO2, absence or presence of thrombocytopenia, bilirubin levels, lactate levels. So all this stuff was being done. I mean, septic patients were being treated appropriately. It's just that now, when they put in Glasgow Coma Scale and then give it scores, whether of 1 to 4 based on what that GCS score is, it means from a documentation standpoint, people will have to do a specific GCS score every 6 hours, or when someone is in the ER, or there is a change of status. And same thing with lactate levels. Those were being ordered. It's just that now they're part of the documentation that requires a complete documentation. I spoke to a good friend of mine. He's critical care in Florida, and he says, now CMS requires the documentation of capillary refill in ICU patients for adequate payment. And, to do a cap refill in an ICU patient, one is not reliable, but it takes 3 seconds. What the workaround has been is the EMR now has automatically, every 6 hours for a nursing and physician documentation, added a pop-up saying, what is the cap refill? Now, there's no data to show that cap refills that are less than 3 are any different from any other volume measuring status, but just the fact that it's now part of a government-required payment methodology, that's where the documentation has increased.
Right, and also there's the SIRS part, and I see that, and I was thinking Dr. Fahuja was going to touch on that as well, but based on the JAMA article that was done, they don't enlist the word SIRS any longer.
Right.
Inflammatory response. They think we should just be using the word sepsis. That's if we're documenting SIRS in the chart, we're going to have that code for sepsis if there is a sepsis. So we should continue to code as we code. If we see that SIRS there, we can still code that code. It's not going to hurt anything. As we move forward, when the changes happen, whatever, the coding, AHIMA, and the cooperating parties decide we're going to do with that, those changes will be made. But for now, we should be continuing to do what we're doing. I think what's critical that Dr. Fahuja was just hitting on, and what Bill, I think, was hitting on earlier, is this Q Sofa here. And the concerns around Q Sofa is that it's going to put a lot of more patients in this population for identifying sepsis. So this is an initial part of the identification of a condition that is fatal. And in that identification, we're probably going to see a lot of possible sepsis documentation. We might see more possible sepsis documentation. And as that patient may be admitted, and then maybe he's discharged on day 2, and it turns out the physician felt he wasn't septic, is he going to rule out sepsis, and is that coder not going to code it into a sepsis population? So that's the potential documentation here, issue here that we could have, because it's going to push more patients into that population so you can effectively treat them. They want early identification to begin early treatment to prevent death. And that's really what this is about.
Yeah, see, that's what it was mentioned here on the, this is one of the pearls and pitfalls on this MDQ Sofa Calculator page. If you go to that page and scroll down, you get even more information about the tool and about that. And one of the things it says is exactly what Sharon was just mentioning there, that there is a, this is a new focus, and basically the focus is on identifying which patients with infections may have a poor outcome. So that's what they're, it's meant to be something that will help the patients. But it does. I kind of agree with.
But Ernie, from documentation standpoint, as far as I know, and Sharon, Dr. Pooja, correct me, I don't believe CMS has stated to adopt this yet. I don't believe anyone other than these groups has said. Is it additional documentation now? I don't think it is. I think your sepsis documentation, if it was good and robust in your current documentation, the way you normally do it now, still should suffice. Now, will Q-SOFA maybe add another layer or add a new direction? I think it might. But right now, I don't know if the payers have fully adopted it. I mean, if I had to appeal something, I think I would probably use it because it's certainly clinical literature. But I don't know who yet is saying, I want to see this in your documentation.
Right, and they're very clear about it, stating on, like, even on this the sepsis criteria tool, which is the second tool on MDCalc about this. The one I just showed was for Q-SOFA. This one is the SIRS septic shock criteria tool, and they basically, they do say this is basically still in controversy. They've been adopted for the purpose of research, and in clinical practice, but they're not saying anything about, they haven't even been validated yet. So, and, I think...
and this is the current tool, Ernie, the tool you're showing now, the SIRS, sepsis, and septic shock criteria. So now, if I'm doing an appeal letter, I'm going to be using this SIRS criteria here with the sepsis and the septic shock, and I'm going to be looking for these clinical indicators, and I'm going to be scouring my chart, trying to validate that, yes, my patient had this, and not only did he have these clinical things, he had these physical things going on that we can see. So this is what's currently in place. The Q-SOFA and the SOFA, it has two elements to it, is what we're planning to move to. And this is what most hospitals are using for their current quality improvement programs, the SIRS criteria.
Mm-hmm. Yeah, and let me go to the, get off this, back to, if I can get my tool to come back. Sorry, I'm having, okay. Here we go. These are some boxes that are a part of that that article that you might want to pay attention to. This is, how they're defining SIRS. And then there's box 2, which is basically about the key concept of what is sepsis. And they're basically saying that, okay, it's here's where they're talking about sepsis. They're really moving away from SIRS, talking about sepsis. And then, so this is where you can find those boxes in that article. And here is where they finally really define it. And then they put up, there's a slide also in that presentation that looks like this and gives you actually a flow chart. Now this is from JAMA Network. It's not my work or any of our work. It's from the JAMA Network. It's a slide available in that article. If you scroll through that article, you'll find the slide for it. And all I did was... yeah.
And I think what's important here, I mentioned the sofa a second ago. So there we have the Q sofa in that upper left box. And that's where you do your initial identification to put all those patients in that population to ensure that we're capturing all the patients we need to begin protocols to prevent sepsis. That's really what this is about, prevention, trying to eliminate death and all of this. And then from there, if, say, you didn't catch it early enough, maybe that patient didn't show up to the ED and they were like a week into their sepsis. You know, they've had that ulcer for some period of time, and it's gone through, and I'll say it, that initial systemic inflammatory response. It's gone from there. It's turned into more, you know, you got that localized infection going on, and it's starting to spread, and it's been late, and you haven't initiated treatment yet. And that's where you go to where you have suspected organ dysfunction, whether that's kidney, liver, whatever. And that's where you start moving into the SOFA score. And that's where it gets, you know, way more where you can get into your possible, gosh, I lost my train of thought, shock. You can get into your possible shock to where things start progressing. So that's really what this is about, identification of those patients, trying to put them in that population where we're treating them and managing them appropriately. But my concern here is that what's that going to do to our documentation? Are we going to eliminate and rule out that sepsis where we're not coding that and not reporting that when we don't have all the other clinical things to go along with it? So it's going to take an effort from physician advisors, CDI, and a knowledge of coders to ensure that we're not putting these patients in there inappropriately so we don't come into compliance issues.
Yeah.
And Sharon, one of my concerns with these grids and these flow charts is I can just see the IT people saying, oh, look, I can just make a template, and this will be covered in a template. And I just think that could really go awry very quickly as well.
Yeah, and they did make the point that clinical consideration, what's the word I'm trying to think of? I lost it. The doctor making a judgment is still a very important part of this. They do recognize that. So it's not, nobody's trying to take the doctor out of it, that's for sure. So now the other thing, it's just like what Bill was saying. If Bill and Sharon were saying, if it's going to affect the documentation, now what does that mean? What does that mean for coding? And of course, then that's going to affect billing. So let's look at what they talked about for coding. They do have some charts and tables. The darn thing is hard to see. So here's how this new clinical criteria will correlate with ICD-9 and ICD-10 codes. Let me see if I can bring that up. I got to find the PDF. Sharon, you want to, or Bill, you were talking about this earlier before the show. We were looking at this because here it's talking about
Bernie,
here's sepsis, here's septic shock.
Chime in here.
Yeah, go ahead.
All these scores that you've mentioned, just for the benefit of the listeners, physicians really don't need guidance in terms of flow charts to know when a patient is septic. This is part and parcel of a daily treatment protocol that all physicians in an ICU do, whether it's hospitalists, whether it's critical care. How we use this is now that we know that, like I said before, from a payer standpoint, they want documentation of cap refill every 6 hours. Physicians who are taking care of septic patients are monitoring fluid status on a real-time basis. But knowing that it's a 6-hour interval that requires a payment is where now they have to come in, put in a notation, whether it's them or their proxy, whether it's a nurse practitioner to do that. So, knowing mental status changes, knowing hypertension, calculating MAP, that's already being done. It's just that now it needs to be presented in a way that is appropriate for the coders to understand and then to bill it. I mean, this does not change the end mortality of a patient. Someone coming in with septic shock due to pneumonia or, Klebsiella bacteremia is going to get the exact same treatment. But if it's not packaged or documented in a way that the coders can now appropriately bill, the hospital ends up losing reimbursement. These definitions, when you look at the history, I'm glad you went back 5,000 years, but the current politics of definitions for sepsis is each group wants their definition to go through. And so this is Society of Critical Care Medicine, and it's looking for endorsement from the Infectious Disease Society of America. There's a whole bunch of politics at play on whose definition is being used. And eventually it does come down, it's a payment module that makes the eventual pass-through, which is why we need to start documenting the way the hospital wants us to in order to get that payment.
Yeah. And it's, somebody made the point in the chat box about CDI, however, do need to know these criteria so that they can query the physician when there's not enough in the documentation.
Absolutely. Absolutely.
The CDI can be the expert. Yeah.
Exactly, because you bring any patient into the emergency room who is hypotensive, tachycardic, altered mental status, and they can immediately recognize, this is tier 1 triage because they know these symptoms, that this is someone who is either going into septic shock or is coming in a far worse condition than someone who's in with a foreign body in the ear.
Yeah, let me ask this, Dr. Fahuja, and anyone else in the chat box, please chime in. So if you're using, we're at that time where we're adopting the Q Sofa, and you have that patient that presents, are you going to be possibly documenting possible sepsis? Or what would you say for that patient when it comes to your documentation, if I can ask that question?
Well, let me just say, I just thinking about that for a moment, Sharon. I think, that isn't that going to depend upon the particular presentation that you get?
Right, but if they meet the Q Sofa and you're thinking it's sepsis, are you going to be documenting possible sepsis most likely?
Sharon, if you go into an emergency room and you get a call with those 3 variables of altered mental status, respiratory rate, and a low blood pressure, you will bring half the tier 1 ER triage patients into the sepsis guidelines. That's just not the way it's supposed to work.
That's my point. And that's my fear about how careful we have to handle that Q Sofa internally at our hospital. What are we going to do with this information? How are we going to act on it? Because you're right, and Bill and I were talking about this earlier. Gosh, how many patients are going to fall into that?
Yeah.
Yeah, what they have now, coined as Q Sofa, these are just a fraction of the criteria that we already use in the hospital to identify high-risk patients. When a rapid response is called, the nurse is telling us, hey, patient in room 613 is confused, the MAP is low, is breathing at 24. There you have the 3 points of the Q Sofa, and that's where a rapid response is already called, but they've evaluated 20 other variables. I want to bring to the group, and I was around when the Apache 3 score came out, and that was a bunch of variables with a score of up to 300 for ICU patients. And the only reason that somehow the Apache 1, 2, and 3 didn't hit off like the new sepsis guidelines is because at that time, a lot of people complained it's difficult to calculate, and how can we have computers in the ICU in patient rooms to calculate Apache scores? Look at this 15 years later, 20 years later. Everyone is walking around with a smartphone in their hands, and every rooms in the ICU have these EMR systems where Apache scores are automatically or can be calculated. So this concept of the new definition is definitely not new. In fact, the Apache 3 had far more variables than these new sepsis guidelines have. Again, the data does show with comparison to mortality, but it doesn't show that there is going to be a treatment benefit if this is documented or if this is not documented. So these are mainly for documentation stuff.
Right. Well, and the KDIGO kind of goes along with that too, Dr. Felicia.
Sorry, say that again?
The KDIGO score?
Yeah, and then same thing with the large score. I mean, any score that will predict organ dysfunction, they all revolve around, there are certain labs that predict organ dysfunction, and lactate has been around for such a long time. Kidney injury has been around. Now, people may argue Glasgow coma scales are not valid when patients are on narcotics or have come out from anesthesia. And in the ICU, the use of narcotics, and I know this is Dr. Hirsch's is a topic about opioid use and hospitalization, but people on chronic opioids who present to the ER may not have a valid Glasgow coma score that can be used more appropriately. Or if we're giving post-colectomy patients IV Dilaudid, you can't be judging their arousal status. I'm just looking at a case from a hospital. There's a note at 3 a.m. from the nurse saying patient not arousable, sleepy. And I'm looking at the time that at 3 a.m., don't do a Glasgow coma score evaluation at that point because the patient is sleeping.
Okay. Well,
all this being said, though, I still think it provides a structure that should the payers and should the government want to move forward with, it provides a little bit of a stronger structure around this whole process that may help us with documentation. Whether it's more, I don't think it is. I think it's going to be different, but I still think it provides a little bit more structure than we've had. Sepsis is a ongoing denial. It is constant, and I think it just provides a little bit more structure around it. Not only for the clinical treatment for sure, if they want to use this, but I think it can morph itself into a nice structure that could be used for the benefit of all who are documenting.
Yeah, I love stuff like this because it gives me an avenue to structure my appeal around. So I like it when the facility has, guidelines that are evidence-based that I can use that's a part of their process.
So I was just going to ask, Bill, how do you think this gets looked at by the auditing community? The next slide I've got here.
Well, I think we should be very clear. For starters, they won't get it. Okay? They're not exposed to it. It's yet another thing they have to learn. They have to be instructed. They have to be instructed properly and with solid instruments, meaning you're going to do this, you're going to do that, this is what it means. The payers have to adopt it too. So, United cannot do something different than Humana doing something different than CMS, which is the most likely event, is they're going to say, well, we do this, we do that. There are going to be payer differences. So I think, first of all, educating the auditors is going to be important. Number two, they're going to have to educate the auditors for what to look for. So if they suddenly see this, what are they supposed to do with it? It will help the internal CDI people, I think, in getting those queries and getting in for that further look in to help them be on stronger platforms. So maybe the denials for sepsis itself will go down. But again, this hasn't yet been adopted by anybody. It's more of a clinical management tool. And until somebody says, hey, one of the payers says, let's do this, or Millman, Interqual involve it very stringently in their process, I think we're still, we'll see it. And most people will have to go Google it, I think, and unless they're very comfortable with it, because it's not yet fully vetted or adopted.
Yeah. Well, my concern is that the auditors may, I would call them uneducated or whatever, but that the auditors and the payers may jump on this as, another way to basically find problems. and it certainly isn't meant to be that kind of a thing. This isn't about. I mean, the changes are not being made in order to affect reimbursement. The changes are being made for the purpose of improving care. So that's the idea.
I like the last comment that do you realize there will not be a perfect criteria? Absolutely. I mean, sepsis has been problematic for a number of years, decades.
Yeah.
Each patient, we're still going to have to look at it. SOFA, Q-SOFA, whatever it is, by itself will not be the answer.
Yeah.
Exactly.
It'll be another data point that could, and I stress could, lead us to better documentation, because I actually don't know where it's going yet.
Yeah. Sharon, I'm going to let
Ron
you
saying that Star Trek Tricorder is coming soon.
Well, let's hope so. Sharon, I'm going to let you talk about this slide. We're almost out of time, but we're right at the end. You sent me this slide. I didn't know what to do with it. I don't know what it is.
Oh, this is just the performance. This is just one of the quality indicators that are wrapped around sepsis that people are like, well, do we still do our PSI 13? And it's just related to sepsis and the definition. And the codes are still going to be there. You're still going to be coding sepsis. It's still going to go to 038, no matter if it has organisms or not. And I don't know, you might have something else to add, Dr. Pahuja. You do quite a bit with this, but I just included a copy that for now they say do what you're doing.
Yeah, but these are ICD-9 ones you've put up, right?
Yeah, this is AHRQ. Mm-hmm.
Yeah. So, I mean, post-op sepsis is a very undocumented disease itself, and just the reason why, because the surgeon gets dinged on a post-op sepsis. So, it's very, I mean, they don't even like to agree that the patient's anemic post-op, because again, that's a ding on their surgery. But
understandable.
A lot of times, again, even in ICD-10, there's post-op sepsis guidelines or codes, and unless it's written, I don't think a coder or can use them. So it needs to be put in either by the hospitalist or by the surgeon itself, and I rarely see that being used this frequently.
Yeah. Okay. Well, so then we get to the end, and I chose. This is again from that Surviving Sepsis campaign, where they talk about, well, then what should you do? And this is what they say. The new definitions do not change the primary focus of early sepsis identification, initiative, timely treatment. So it's moving along. They're doing something. This is an image of from a hospital in the UK who one of the ways that they chose to address this kind of thing in the real world was by putting a sepsis box, putting sepsis boxes on every floor, I guess. And so it's just you should be thinking about it. I guess is the thing they're saying primarily. Like, you want to make sure that you are educating physician and nursing staff and coding departments so that they can capture the sense of the new definitions. So, again, I think I agree with, I may be,
you're on.
Okay, my screen, well, my computer says it's disconnected anyway. So we'll see. Let's see if I can actually change slides, because I was going to point out some more. Can you see the slide change?
Yes.
Okay. Oh, okay. There we go. Now it's on. All right. So, and here are 3 documents that Dr. Pahuja sent me before the show, which I thought will be helpful. In particular, this one down here is the ICD-10 codes about sepsis with an unspecified organism. So, and somebody was saying, yeah, it's a good thing that ICD-10 has codes for sepsis with infection and without infection. Here are more about definitions. Again, that comes from those JAMA articles. And this was a very nice infographic, and it's too big to show here, but I give you the link here to go look at it. I think it was a very nicely done infographic that talks about why it's important and what you should be doing to help. And yeah, I think viewer 181 is saying, did anybody else's screen go black? It may have. Yeah, mine kind of disconnected for a moment there. I don't know exactly what that was about. Do you still have a black screen, viewer 181? I think not. Mine came back. Maybe yours connected or not.
Yeah, I'm
okay.
connected.
Well, apologies. Okay, so apparently it's only affecting a few people. Sorry about that. We gotta love the internet and technology, right? Okay, so listen, that's all we've got time for today, but I do want to remind everybody we do have some shows planned coming up in April and even into May. Not exactly dates on some of those, but on April 1st, yes, no fooling, I've actually got Dea Gaskisa and Dr. Maria Johar going to come on the show and talk about okay, yeah. Dr. Hirsch says I've got one sofa point, altered screen status. Okay, so anyway, we do have a show. I'm looking forward to that because it's very hard to get Dea Gaskiza on the show, and she doesn't get on many shows. You usually have to go see her in person somewhere. But anyway, she and Dr. Johar are talking about that, and it's really kind of a preview of a bunch of talks coming up in the physician advisor UR Team Boot Camp that's coming this summer in San Antonio in July, so we'll talk about that. Anyway, I just want to thank everyone for being on with us today. That's certainly all the time we have for. We'll be back next Friday, March 25th, and I think we will have another presentation about sepsis. It'll be some new information. I'm going to try to get a few physicians that I know who are doing some interesting things with it. Thanks to everyone for participating today. Special thanks to everybody in the chat box. And, of course, thanks to Dr. Prahuja for being here and sharing his information about it and his view as it. And, of course, my co-hosts, Sharon Easterling and Bill Mom, they are always a big help and contribution. And, of course, we owe thanks to our sponsors, Health Law Partners, Medlings, Cost Containment, and Mass Coding Solutions, because it's their contributions that do help keep this show going. So watch for my emails about next week's show. Please share the links to our show with your colleagues and friends. The last thing I want to do is share my favorite image of the week. We're talking about change this week. Some things don't really change. And I'm not even the guy who said this. It's been around, the quote's been around for a long time. Mark Twain said, politicians and diapers must be changed often and for the same reason. And with everything going on today in America, that's certainly true. So anyway, thanks everyone. Thank you for watching, and we'll see you next time when it's finally Friday. Have a great weekend. Bye-bye.
All right. Thanks, guys. Bye.
Sure.
Thanks, Dr. Prahuja. Thanks, Bill. Bill, you
Bye-bye.
All
Have a good weekend.
You too.